This video is for education and entertainment purposes only. Please consult with your healthcare provider before making any changes to your health plan.
Hey beautiful soul, it's Jacqueline from the Lost Labia Chronicles in partnership with Lichen Sclerosus Support Network. If you have lichen sclerosus and are looking to empower yourself with information, find acceptance, and reclaim your life, then please subscribe to our channel and keep on watching. And if you have a friend or family member or loved one with lichen sclerosus and you want to learn more about the physical and mental health aspects of living with lichen sclerosus so that you can better support them in their journey, then please keep on watching and please share this channel with them. All right, so in today's video, I am joined by the brilliant Dr. Aurora Almadori, and I have been so excited to have this conversation with Dr. Aurora. I know that so many of you are going to be really interested in this topic and in this conversation. So today we are going to be talking all about fat grafting. Yes, fat grafting. We're going to be talking about its potential to help with fibrosis, scarring, and sexual pain. So we're going to kind of start off by having a conversation about what steroids can and cannot do. We're then going to talk about the differences between PRP, so platelet-rich plasma, stem cells, and fat grafting. And then we're going to really dive into the heart of things and talk about fat grafting and its potential role for ameliorating the lives of folks with lichen sclerosus. So for folks who are unfamiliar with Dr. Aurora Almadori, Dr. Aurora Almadori is a plastic surgeon with a focus in vulvar health and regenerative medicine. She's done a lot of philanthropic work doing reconstructive surgery for folks who have survived female genital mutilation. She is currently based in London, UK, and that's where she does a lot of her plastic and regenerative work. So we are very thrilled to have Dr. Aurora here with us today. She has quite an impressive bio. We will have that full bio linked in the description box below, so feel free to go read through that if you want. And as always, if you find the information in this video helpful, then please give us a like, give us a comment, give us a subscribe, and with that, let's jump into the video. All right. So thank you so much, Dr. Almadori, for joining us today. I've been really excited about having this conversation with you, and I know many people in the community really want to hear this as well. So before we kind of talk about fat grafting and its potential for helping with fibrosis, scarring, and sexual pain, I'd love to just learn a little bit more about you and your journey into the kind of reconstructive and regenerative medicine space.
Well, first of all, thank you for this invitation. It is my absolute pleasure to share with you our thoughts on a new treatment for lichen sclerosus. So how I got into this field, this is a good question. Actually, it is, I think since the first year of my medical school that I got involved in different projects about women health, different, like I would say a wide variety, including, for example, FGM survivors, women with female genital mutilation, where basically they have, for cultural reason, all the parts of the vulva cut since a very young age. This includes cut of the clitoris or the labia minora. And then I also developed a passion about research, particularly in stem cell research. And then I got involved in projects using those new treatments for scar. And then kind of combining the two, I got into a clinical interest in vulvar reconstruction.
Wonderful. Well, thank you so much for sharing that. So what I want to do is I want to kind of set the scene and give some context to our conversation. So we're going to be talking about fat grafting, but when we think about treatment, we think about steroids, right? That's like kind of our immediate connection. So I'd like to kind of talk about what steroids can do and what they can't do. So if you can maybe just comment a little bit on that, that would be great.
I think that's a very important aspect because steroids are the treatment, are the gold standard, are the treatment with efficacy, sound evidence, randomized clinical trials confirming this, which is randomized clinical trials as the highest level of evidence in the medical field. So steroids are good treatment, and they help to reduce the inflammation, to reduce symptoms, to avoid disease progression, and also prevent evolution to the cancer. Unfortunately, steroids cannot work on the structures of the vulva that are gone in the meantime. Sometimes, this is a disease that progresses with time, and sometimes diagnosis is delayed for a number of reasons, unfortunately. And when a woman arrives to a specialist with a proper diagnosis, sometimes the labia or the external part of the clitoris are already gone or reduced or impacted massively, and steroids cannot, unfortunately, have an effect on that. So this is where we're trying to kind of complement with additional therapies.
Yeah, I love that. So that definitely resonates with me, because it took me almost 11 years to get diagnosed. And by the time I was diagnosed, my labia was completely gone, completely resorbed. I had significant scarring of the clitoris. So it's very common, because there's that delay in diagnosis, because it's progressive, for many, but not everybody, for many of us to have some degree of vulvar scarring. And that's really important, because scarring is a lot of what leads to sexual pain for people with lichen sclerosus. So we always say that, scar tissue is thick, it's rigid, it's not very flexible. And because it's not flexible, when we try to insert something into the vagina, that skin can often crack and tear. So people will commonly say there's tearing and pain around the fourchette area and like the opening of the vaginal opening. Those are common sites that can be affected by scarring, and then of course the clitoris and other areas too. So we know that kind of scarring can go hand in hand with sexual pain. So that adds this extra layer. So one, we've got the anatomy changes, but now that can lead to sexual pain. And when you experience sexual pain, your mental health is almost certainly going to be impacted, because now there's difficulties in your relationship, you're worried about dating, it's very, very distressing. And so one thing I always talk about with people is the distinction between treatment and then managing symptoms and improving your quality of life. Because steroids alone doesn't necessarily improve quality of life, especially if there's a sexual pain aspect, and especially if you've got changes to your anatomy. And I think this is what really drew me to your research initially, and why I thought it was so important, was because of that piece of what steroids can't do. And that part of what they can't do is a really big piece for a lot of people with vulvar lichen sclerosus. Those anatomy changes, that sexual pain, and their quality of life is so, so, so important. So before we jump into fat grafting, one thing that I really wanted to chat with you about was if you can tell us what the difference is, or if there is a difference between stem cells, PRP, and fat grafting. I think there's a lot of confusion in the community. Some people lump it all together. It's the same thing. So I'm hoping that you can give some clarity there.
Absolutely. Thank you for this question, because this is one of the main aspects when a woman goes to a professional to have an issue addressed. It's important that clear information are given and the full understanding is received. There's a lot of confusion. There are some similarities. We talk about regenerative surgery, regenerative treatments, which basically means using part of our own bodies, having cells, tissues that have the capability of regenerating, stimulating other cells around. But there is a big difference among each other. So one of the difference is about how the treatment is performed. When we talk about fat grafting, we're talking about basically taking fat from one area of the body, could be the tummy or could be the lateral thighs, and then processing it and to extract a fraction of this lipoaspirate, which is a cocktail composed of different cells. including stem cells. So this type of surgical procedure has been around for many years. I think the first time that it was described was the 1893, so it's more than 100 years ago. Wow. It was used to correct depressed scar, I think in war injury. Mm. And then obviously the technique evolved over time. Before they were just taking a piece of fat and putting in another part of the body, and then there's been a more refined and sophisticated way of processing this fat. But the concept remained the same, using adipose tissue, fractionated and selecting a fraction of it, which is rich with adipose stem cells, and re-injected in another part of the body. Now, the indication of this type of treatment initially has been mainly for volumetric reason, because we are injecting adipocytes and other cells, and this gives volume. And then, like sometimes, I would say often happen with the medical practice, things and knowledge evolved, and in the early 90s, researchers from the US found that the adipose tissue is a source of stem cells called adipose-derived stem cells. So those are mesenchymal stem cells from the fat. And this is when really the interest in this technique started being massive, because there was not only a volumetric effect, but there was also a regenerative effect mediated by the stem cells. So when we talk about fat grafting, we're talking about injecting a cocktail of cells composed of adipocytes, pericytes, vascular cells, extracellular matrix, and adipose-derived stem cells. This is fully compliant with the most regulatory bodies of Western countries, let's say, because there is no manipulation. We do not extract the cells, the adipose stem cells in the lab and re-inject in the patient. We just process them. It can be through centrifugation, through washing. There are different ways. I wouldn't go too much in detail on that, but the concept is that it really consists in selecting a part of the adipose tissue where there are many cells, including the stem cells. So this is fat grafting. Sometimes this is advertised as stem cell treatment. Mm-hmm. Not technically correct, because we know that there are stem cells, but we do not really target these cells. We inject kind of their stem cells within their niche, which is basically their home, all the surrounding components that are around them. When we talk about stem cell treatment, we talk about more elaborated process, which consists in extracting the adipose stem cells from the fat. This is done in a lab with certain different methodologies, and then those stem cells are injected. So the volume of the stem cells is much smaller than when we inject the cocktail composed of fat and whatever. So when we talk about stem cell treatment as injection, we do not have any volumetric effect. And I'm saying this because there is a big difference. When we do fat grafting, we obviously, in lichen sclerosus, we aim at improving the scar and the skin tissue elasticity, as you said, particularly in the posterior fourchette, because we know that this is a big issue for most of women with LS. And so injecting fat, we can increase the soft tissue. It's like we have a sort of a cushion effect, a padding effect. We create some extra space, and this usually helps even with the penetrative intercourse, because the skin is not that thin and attached to the underlying structure, but there is an extra padding, let's say. So it usually helps with sexual function. We can also use this to increase the volume of the labia majora. So the indication is really combining the regeneration of the skin along with a mild increase of the volume. I say mild because we always have to explain very carefully to women in order to manage the expectation. We can't reconstruct fully, let's say, a labia minora with fat grafting. We can increase a little bit if there is a partial resorption or if there is some shrinkage. But if labia minora are completely gone, we can't replace them with fats. But we can work a little bit on volumes. When we talk about stem cells, it's just about targeting the skin and the fibrosis and whatever the indication is. But there is no volumetric effect, no effect on the anatomical structure of the vulva. And one of the most important things that we also have to consider is regulation. For example, in the UK, to extract the stem cells, we need to use an enzyme which is called collagenase. But once we do that, we cannot re-inject these materials into human bodies because the collagenase is not allowed. So this is considered substantial tissue manipulation, and therefore we cannot re-inject this. Different countries have different regulations, but this is something that we always need to take into account.
Right. And then where does PRP come in?
Yeah, the PRP is a completely different process, but there's some similarities. So the PRP stands for platelet-rich plasma. Mm-hmm. It comes from the blood and not from the adipose tissue. So basically, the peripheral blood is taken out as a normal blood test, and then is centrifuged in a specific machine. And the different fractions are separated, and only one part of we obtain like a different layer solution, and only the part which is composed of platelet is extracted, and this is why it's called platelet-rich plasma, because platelets suspended in plasma, and the platelet have contain granules full of growth factors and cytokines which can affect the tissue where they are injected, similarly to the adipose stem cells. But it is a different process, and it's just about injecting platelets with good, let's say, good molecules, rather than injecting alive cells that can interact with the surrounding structures, like the adipose stem cell do.
And then, so I'm going to presume that platelet-rich plasma also, like stem cells, doesn't have that volumetric effect.
Right, it doesn't. It's just, let's say, a liquid solution. Mm-hmm. The aim of this treatment is just to improve the skin quality or to reduce inflammation.
Perfect. Okay, well, thank you very much. I learned a lot. I appreciate that explanation. So moving into fat grafting then, you did an initial study, a prospective cohort study in 2020. I was curious to know if you can share some of the results of that study with our audience.
Yes, that was our initial study. Was a prospective cohort study, which means that women were assessed before the treatment and then after treatment at different time intervals. And we look at different aspects. The main ones were related to the sexual function. So we use validated questionnaires, which means questionnaires that have been already used in previous research that have been proven to be reliable and consistent. Mm-hmm. And so the sexual function was our primary outcome, because we've seen that women after this treatment were reporting an improvement, especially as we were mentioning before, with the splitting in the posterior fourchette. So we really wanted to look at this with validated outcome measures that could be quantifiable. And then we look at different other aspects, including the impact that this treatment could have had in their relationship. We use a specific scale to look at the romantic relationship. And then we look at other aspects like anxiety and depression and social anxiety in terms of fear of being negatively judged by others, by a partner. And we found very good results, particularly in the sexual function and in the intimate relationship. And so we found that these results were encouraging, and this is why we decided to continue the research in this field. Because when we started this study, there was barely nothing published. There were just a few small series of case reports, but without a very clear outcome assessment and without very specific details of the technique and how things were done. Sometimes there was fat alone, sometimes fat was mixed with PRP. So we really wanted to understand if there is a role for those new treatments in ALS.
Mm-hmm. Yeah, I remember reading the study and thinking that it looked quite promising. I love that you used multiple measures because sexual health does impact mental health. So it's nice that, you know, there was multiple things being looked at. And if I recall correctly, there was improvement with every measure that you looked at. Sexual pain, the texture of the skin looked healthier. So I think the skin was assessed clinically, right? Is that how the skin was assessed?
Yes, absolutely. I would say that the fibrosis and scarring has been the main aspect that improved and that consequently had a positive impact in all the measures that we have included, quality of life and everyday function.
Right. Yeah, so skin improved, therefore sexual pain improved, therefore sexual health improved, therefore mental health and quality of life improved.
Right.
So
we always have to remember that pain has different components. There is an external component made of the skin, which we can try to address with the fat grafting or other treatment. And then there is an internal component because our vulva, it's a very complex structure. There are the muscles inside the vagina and in the surrounding area. So there's also an internal, let's say, muscular component of pain, and this can be addressed with managed with physio and another way. So it's always important to kind of explain that we can't promise miracles in regarding pain because it's a multifactorial aspect. But definitely the skin improves, and then this means less splitting, and the bleeding during intimate relationship can be embarrassing, and then it can lead to avoidance of intimacy. So being able to accommodate penetrative intercourse have a positive aspect also in other aspects of quality of life, including being in a relationship positively and not avoiding that.
Yeah, avoidance is really big. That's definitely something that happened with me because I developed anticipatory anxiety with respect to intimacy and penetration. That anxiety led me to develop avoidance-like tendencies that created strain on relationships, that created, distress in my mind. So I do agree, and I love how transparent you are. And we can't promise miracles. And I think when we talk about pain, it really is biopsychosocial, and so it is about addressing all of those different pieces. So potentially fat grafting, but also pelvic floor physiotherapy, maybe even going to see a sex therapist to work on some of those avoidance tendencies that we tend to develop. So really building up a nice cohesive package to help address the issues that people with lichen sclerosus have. So
this is why it's so important that the management of lichen sclerosus has to be managed by different specialists working. So it has to be teamwork, multidisciplinary teamwork.
I agree. And ideally, they are working together and not separately. But yes, 100%. And that kind of just goes to show, even with steroids, which are the gold standard, it's like you don't just, I always tell people, you can't just like use steroids and then expect that your whole life is going to change. There's still the mental health, there's the physical health, there's the pain component. There is so many. So a multidisciplinary team looking at this from multiple different angles is so, so crucial. So I love that. So the initial prospective cohort study showed promise. So from there you thought, okay, let's do a randomized clinical trial, which, as you said, is kind of the highest level of scientific robustness when we're talking about like, okay, we have full confidence or we're very confident in this treatment. That usually comes from randomized controlled trials. So you are currently in the design phase of an RTC to look at the efficacy of fat grafting for fibrosis and scarring. Can you tell us a little bit about that trial?
Yes, so we are designing this study as you said, it will be a feasibility trial, which means a first initial step into a bigger randomized control trial. And we think it's very important to run an RCT on this topic because we really need to know the impact of it and with an evidence-based approach. Obviously, we have a very rigorous method when we perform different studies. It can be prospective cohorts or case series, but there are always many factors that can introduce bias that are out of our control. So the clinical trial is very important because the design itself of the study makes sure that all those variables are kind of controlled, and we have, as you said, a higher level of evidence, which means that the results are reliable or very reliable. So in this study, we will look at the fat grafting in lichen sclerosus. We will also have a second group with a platelet-rich plasma, because women are asking for this treatment more and more. Mm-hmm. There are a few studies that has been published in the meantime since we started the previous study that we've discussed before, and so we decided to include this treatment and as well. And then we will have a third group, which will be a control. And the control group will be standard of care with topical steroids. So basically these three groups will receive different treatment, and they will be assessed with the same outcome measures. And then at the end of the study, we will analyze the results to see if there is a difference and what the difference is. And all this is done in a, let's say, in a blind way, so it will be reliable.
Yeah, again, blinding is very important because that's one of the ways that you can reduce bias from kind of infiltrating your study, so to speak. So blinding, for folks that aren't familiar, doesn't mean that Aurora literally can't see. It just means that there are certain methods in place so that if Aurora was the clinician administering the treatment, she wouldn't know what she's giving the patient. Maybe it's PRP, maybe it's fat grafting, we don't know. And the patients also usually don't know too. The patients are usually blinded too, so they're not sure if they're getting, if the injection is PRP or fat grafting. So again, it's a really good way to get more clear, reliable results so that we're kind of weeding out that bias. One thing that I forgot to ask about the fat grafting is kind of the pain during the procedure. So are patients awake? Is it typically a painful thing? Do you use a numbing cream? How does that kind of work for the administering part?
Yeah, so the treatment can be done with in different ways. There are different techniques described. They involve using different cannula, different cannula sites. So there are smaller cannulas, larger cannula. Then the fat can be processed with centrifugation and, as I was saying before, washing or decantation and so on. So what we usually do, I like to use small cannulas for a number of reasons. One reason is that it's less aggressive to the donor area, and then processing this with centrifugation or other methods, and then re-injecting it again with very small cannulas. These also help us to select the lobule size that we want to obtain, because we don't want to inject too much, because then it will not survive, it will not be integrated in the host tissue. While if we inject smaller amount with the right technique, then the fat and all the cells will survive because they will get blood supply and they will be integrated in the vulva. So the procedure is done with anesthesia, obviously, so we try to minimize the pain. There is always some discomfort postoperatively, which is associated with most of surgical procedure.
Yeah.
This procedure can be done under general anesthesia, where the patient is completely asleep, so she doesn't feel anything during the procedure itself, or it can be done under sedation. Still, the patient doesn't feel pain because we don't want to create any unnecessary distress. And then we can inject local anesthesia in the donor site area or the other. So there are like plenty of ways to minimize the pain.
Okay, yeah, because you're right. So when you said you're going to do a PRP group as well, I was thinking, so there is a lot of interest with PRP and with these regenerative treatments. But when people ask me questions about them, a big question is like, is this going to hurt? Because I'm already in pain. So you have a pain patient getting a treatment that might be potentially painful. There's usually a lot of worry about that. So it's nice to see that there's, you know, a lot of things put in place so that the pain is minimal. And of course, post-op discomfort is kind of, you know, expected. That's true for laser or any other of these modalities. There can be some discomfort after, but usually if your clinician is good, they'll kind of counsel you on what to do after to, you know, stay as comfortable as possible. So that is great.
PRP is not a surgical procedure. Let's say it's not done in theater with anesthesia. There's no point in doing like a general anesthesia or sedation just to harvest the blood, which is not it's not very painful. For someone, I know it can be painful, it can be a bad experience, but usually it's done with some numbing cream or in some cases local anesthesia, but we do not know if the local anesthetic have an effect or not on the platelet. We try to minimize the pain, obviously, but it's not done under, let's say, anesthesia.
Yeah, fair. And then, so this trial is UK, is that correct?
Yes.
Yeah. Okay. And then let's say that the results of this trial are positive. Is fat grafting something that could potentially be offered to patients immediately after those results are published, or do we need kind of more replication type studies to kind of validate those initial findings from the RCT before patients can start to access this?
Well, fat grafting is already offered in some hospitals in the UK and other countries in lichen sclerosus.
Okay.
Obviously having sound evidence from a clinical trial will make it probably more available, and it will increase the interest of other centers in offering this treatment. And even if from the study we don't have, let's say, how can I say, like good results, bad results are still good results.
Mm-hmm.
So even if we see, okay, this treatment compared to this other is not as good, but still this is a good result because we are comparing also different treatment, and so we think it's important to be open at whatever the answer from the trial is. It will help clinical practice to offer more widely certain treatments that currently are offered in certain regions and not in other, but also just not to offer them or just to manage women's expectations. Sometimes often they go to other countries or they go privately. And if there is evidence that the treatment doesn't work, I think it's good to know that.
Yeah, I agree, because I have heard of a lot of people getting on a plane, going to a different country for, you know, these different procedures, and that costs a lot of money. That's a lot of money. That's a lot of time, and that's potentially some time off work to recover. So it is important that people are very informed about what they're going to put their money towards. So informed consent and managing expectations are incredibly important. And so I know that there's no definite answer on this, but when can folks hope to hear results from the RTC? Because we know that these things take time.
It will take quite some time because we're not designing the trial. By the time the trial starts, we have to recruit women, randomize them, offer the treatment, do the follow-up. And we always have to consider that we do not treat all the women at the same time. So there will be different, let's say, different months. They will be enrolled at different times. So the study will take a long time, let's say.
Yeah, That makes sense.
That we run over 3 years, and then we have to analyze the results and spread with the community and the scientific community. So at least more than 3 years.
I think people are often surprised at how long science actually takes, how long it can take to do these types of studies. I think a lot of times we think like, oh, okay, like a year I get the results, and it's like, no, it can take a year just to design the trial, let alone doing the work, analyzing the results, putting that into a paper, submitting that paper, potentially getting reviewer feedback saying, change this. So you change it, then you resubmit, and then you wait for the publication. Yeah, it can take a lot of time, for sure.
Particularly the design is important because we want to make sure that there is no, I said everything has to be done in the right way, following a process, and there are different people, different specialists involved, not only doctors, but also statistician and clinical trial unit. So it's quite a big process.
Yeah, it really is. So thank you for your dedication to kind of stick through that lengthy period for our community. We appreciate it very much. Before we close, I just wanted to, we touched on it briefly, but I want to kind of make it more explicit, because one thing that we hear in the community all the time, and I say it all the time, is, can someone please build me a labia again? So I know folks are interested in this volumetric effect. So you did state that, you know, if you've lost the labia minora, you can get some volume back, but it's not the same as like having new labia minora. It's not growing labia minora. It just might kind of slightly plump up the area. So do you ever foresee a place where folks with lichen sclerosus can get reconstructive surgery for their vulva, such as the labia minora? I know for a lot of folks, it's the loss of the labia minora that is very distressing. And a lot of people are like, well, we can reconstruct vulvas. Why can't they do it on us?
Absolutely. There are different techniques that's been described to reconstruct labia minora, and these are applied to different conditions that can be done in the context of FGM, or even in gender reassignment surgery, for example. So we're talking about very different contexts. But at the end, it is what it is, and there are techniques available to reconstruct labia minora. Mainly, it's local flaps, which means that the local skin of the vulva is moved around, is advanced with specific techniques, and the final result is to have new labia minora. I think one of the limiting factor of having these reconstructive techniques not being widely adopted for lichen sclerosus is about the carbonization phenomenon. So everybody's scared to kind of reactivate the disease, because we know that the lichen sclerosus, some tissue trauma can reactivate the disease or can create a flares up. So the use of surgical procedure, or let's say more invasive surgical procedure, compared to grafting, where we're just really making a very small hole and inserting a cannula, and that's it. But with flaps, we move a little bit skin around. It's not a major surgery. It's not at all a big type of surgery, but it's still considered more invasive. And I think this is one of the reason why in the scientific community, there is a tendency to be cautious rather than just explore that. But I'm aware that there is an effort on this way as well.
I'm just going to keep crossing my fingers that, you know, if you're in remission and well controlled, and one day, maybe it'll be more widespread. But that does make sense. I've definitely spoken to clinicians in North America, and they say the same thing. It's that re-traumatization of the tissue that makes them apprehensive to perform any type of extensive surgery. Like you said, it's not the same as open heart surgery, but it's still quite a big surgery, and lichen sclerosus tissue is different from regular tissue. So if somebody's lost their labia minora due to female genital mutilation, that tissue is still healthy tissue compared to lichen sclerosus tissue. So there are extra levels of complexity that make it not as straightforward as we think it is. So definitely a lot of caution needs to be put in place when we talk about these things. Well, thank you very much, Dr. Almadori. Was there anything that you wanted to say on the topic of fat grafting before we kind of close out that we didn't get the opportunity to mention?
First of all, thank you for these chats that we had together. I think that the most important message that I have when somebody's interest is in fat grafting is really being aware of what this treatment is, and that it should not be claimed as stem cell therapy. So always make sure that the person you are referring to knows this technique and clearly explain to you how the fat is processed and how it works, and make sure that it's not something which is not very clear. That, I think, is the most important thing.
Yeah, so don't rush into things. Don't make a snap decision based on, availability of some treatment on your Google search. Really take the time to ask the right questions and to really think things through and educate yourself before going into these things, because there might be a lot of money involved, especially if you've got to travel. So I think, again, just informed consent is at the heart of all of this. So yes. Thank you so much, Dr. Almadori, again, for joining us today. This has been a wonderful conversation. I've learned a lot. I'm sure our audience will have learned a lot as well. So thank you so much for your work and for your time. And to my viewers, that is it for this one. We'll catch you in the next one. Bye.
Bye.